Hi, everyone. I'm Amy Pirouet. I'm a family physician, care of the elderly physician in Corner Brook. I've been here since 2013. In 2019, I took a pause from my community-based family medicine practice and did my care of the elderly certificate of added competence in St. John's or through St. John's, and have been working mostly in older adult care since that time, though I do a little practice share in primary care with one of my old colleagues. And I do some transgender medicine, gender affirmative care. I've given up a lot of my acute care stuff, I'll say, but we still do a little bit of hospitalist locum work as well if it's absolutely necessary. So what I've been asked to present on today is how our family medicine residents reach their care of the elderly competencies through their family medicine training. And so what we'll do today is we'll talk a little bit about the objectives themselves. We'll talk about how our learners are achieving these competencies in general. I'll go through the stream-based opportunities for our learners. And then I wanted to do a quick talk about frailty and the comprehensive geriatric assessment. And for some of you, these phrases will be things that you've known forever. And for some of you, they may be more new terms. I think you'll see as we're moving into the future of older adult care that the term frailty will become somewhat ubiquitous. And you'll see why. What I hope to get out of this presentation is the idea that we should be measuring frailty as family physicians all the time, and we should be having frailty scores follow patients through their interactions with the healthcare system because it does impact how we should be treating these patients. The comprehensive geriatric assessment, again, is a specialized tool that most family physicians don't have the time to do in its entirety in one visit. But there are certain bits and pieces of the comprehensive geriatric assessment that I think are great for family medicine and for teaching. And so we'll chat about that briefly. And then we'll talk a little bit about the future of how we can help our learners reach their care of the elderly competencies. So I can appreciate these objectives are very busy slides. I'll go through them, but what I'd like for you to do as we go through these objectives is consider where your learners see these things. And so I think what you'll see quite quickly is that a lot of these objectives are longitudinally seen in every single rotation, potentially with the exception of pediatrics for those who are doing pediatrics rotations. So just consider while you're looking at them where your learners are seeing these things. So how do they assess and manage atypical presentations of common medical conditions? So our older adults who present to the emerge in an NSTEMI without chest pain. Describe changes seen with aging. And that could be changes seen with aging in terms of physiological changes, so decreased metabolite clearance at the liver or the kidney. It also includes changes in terms of pharmacokinetics and pharmacodynamics. Understanding frailty, performing cognitive assessments, and there's a variety of those, though they're not listed specifically in our current list of objectives, and the importance of using collateral history to do cognitive assessment. Functional evaluations, how we differentiate between delirium, dementia, and depression. Manage and assess some common geriatric presentations. So delirium, the more common forms of dementia, assess and manage somebody's driving, assess and manage capacity in various domains, a wandering patient, a medication list, pharmacologic therapy, and assessing and managing caregiver stress. There's lots more. This is just the first slide. We also need them to be able to assess gait and balance, and they do need to understand some basic standardized tools. Evaluate, manage, and prevent falls, including a differential diagnosis as to why people are falling. With an interdisciplinary team to develop and implement care plans for the management of patients with functional deficits. Identify consequences of immobility and work with your interdisciplinary team to prevent, manage, and treat that. Do a medical review, do a medication review, I think is what that's supposed to say, and outline the pharmacokinetic changes that occur with aging and be able to modify medications secondary to that. Look at medications that can cause adverse drug events, evaluate and manage urinary incontinence, identify and manage end-of-life care issues. This was an interesting one for me. Paraphrase the key principles of the Mental Health Act, describe advanced planning directives, and if I can, that's it. So I can appreciate that that's a huge number of objectives. this is what we hope our learners achieve through the course of their 2-year program. I'm going to pause for a second in case anyone has any questions, but then we'll move on to where we kind of see this. And the next slide is probably what you're all thinking. So I'll just leave this up in case anyone has any questions about the objectives themselves. And as a heads up, I don't think I can see the chat. Let me see if I can open up the chat. Oh, I can. Okay, we're good. Okay. So I think as you've all probably gathered through that list of objectives, our learners see most of these things everywhere. You'll get it through your family practice rotations. You'll see certain presentations of chronic disease in the emergency department. You'll be looking at adverse drug reactions or events in the emergency department. Surgery, where you're looking at chronic health conditions and how we manage them, certainly looking at functional assessment, and hopefully in some of the rotations, including orthopedic surgery, an interdisciplinary approach to mobility. Psychiatry, certainly in terms of the, oh, thanks, Dr. Broderick. Psychiatry, particularly in terms of the Mental Health Act, but also, of course, you're seeing that in family medicine and emerge as well. Gynecology, so in your gynecology rotations to see urinary incontinence and different interventions that we can look at for older adults with urinary incontinence. So I think the main point to take out of this is it doesn't necessarily require a block-based older adult care experience in order to see all of the things that you need to see in your care of the elderly objectives. Can it be useful? Absolutely. Doing, all of those things in a care of the elderly block, it can be useful, but it's not absolutely necessary. And so you'll see that as we go into our no, this is frozen on me. We'll get into our current state in terms of our different streams in the next slide. So in terms of specialized resources, so family medicine sees all of this. What special resources exist for learners if, that's part of the curriculum that they have available to them, depending on what zone they end up in? If they want to seek out their own experiences, if they're not seeing all of these objectives in their rotations longitudinally. So geriatric and care of the elderly have dedicated services that exist in Eastern Urban Zone, Central Zone, and Western Zone. And recently, Lab Grenfell Zone has a traveling clinic to Goose Bay where one-on-one assessments with a care of the elderly physician are being done. So in Eastern Urban Zone and Western Zone, there are inpatient consults available at tertiary care hospitals. In Central Zone, we have one care of the elderly physician who does community outreach clinic, supports the home dementia program, but without the HR complement there is not able to do inpatient consults. There are these new concepts called the ACE unit. And if you guys aren't familiar with that term, it stands for an acute care of the elderly unit. And so when the new hospital was being built in Corner Brook, without any of the family physicians or care of the elderly physicians or geriatricians knowing, there was a plan for an ACE unit. And so when we got involved, we really kind of took the ball and ran with it. And now there is a unit at the new hospital in Corner Brook that is specifically for older adults admitted to acute care from the community with a plan to return them to community with senior-friendly policies in place, a huge multidisciplinary team to keep people mobile, to address geriatric syndromes, and hopefully get them home without becoming deconditioned or having new geriatric conditions. For those of you in Eastern Zone, there will be an ACE unit opening in Eastern on June 2nd, from what I understand. I think it's St. Clair's. And so it will also be a service that your patients in the Eastern Zone will have access to. And then, of course, there's Community Outreach Clinic, which is like your consult-based service that exists in Central, Eastern, Urban, Western, and now Lab Grenfell as well. For those who aren't familiar with restorative care units, Western Zone has had a restorative care unit for 15 years, maybe. Restorative care unit was the first one that existed was in Corner Brook in Newfoundland and Labrador. And the idea of the restorative care unit is it is mainly for older adults who are in hospital potentially get a bit deconditioned and don't have any more acute medical issues that need to be treated, but need the help of a multidisciplinary team to restore themselves to a level that allows them to get back to the community. And so that means community living in their own apartment or house, also community to the point of living in a personal care home, but not for long-term care patients. And so these are people who need some tender love and care and a multidisciplinary physiotherapist, occupational therapist to strengthen them to get them back home again. And so there will be a restorative care unit also opening in the Eastern Urban Zone in the coming year. So those are other opportunities for your learners to do, longitudinal day a week or half day a week, or to identify learning needs that they have and be matched with some of these services in the areas where they exist. And then, of course, there's the home dementia program, which right now exists. The Eastern Urban and Rural Zones, it's based out of St. John's, but they do travel to the rural areas of Eastern Zone as well. It's also launched in Central and Western Zone with the hope to bring Lab Grenfell on board within the next year. The Home Dementia Program is a program that is run by a multidisciplinary team. So it's nurse practitioners, and depending on which region you're in, there are different multidisciplinary team members who are a part of it. So for example, in Western Zone, we have 2 nurse practitioners, a social worker full-time, an occupational therapist full-time, and then we use community-based resources otherwise through community supports. And the patients in these programs have a diagnosis of dementia and live at home. So anything up to, I apologize, depending on which zone, definitely living in your own home. In Western, it includes personal care home. In Eastern, it doesn't include personal care home, but not long-term care. And the idea here is that this program can provide some primary care if they don't have a family physician, but liaises with their family physician if they do have one, in order to do home visits and provide care in the home in the hopes of preventing them from having to go to emerge for care and delaying time to institutionalization. So I'm going to pause for a second and see if there are any questions about these specialty resources that exist across the province for our learners.
Hey, Amy, it's Jen. I just logged in. I just wanted to chime in about the Eastern Home Dementia Program, because some of you may know we kind of paused our intake back in June of last year due to some significant staffing issues, and we're hoping to have that back up and running in hopefully the next number of months, to be able to take some new people in our program. But we have 2 new nurse practitioners, so we just got to give them time to get their feet under them first.
Wonderful. Thanks, Dr. Perry. And so I think you can see that this is a program that is staffed by very few number of individuals. And so any leave, any sickness for any of these programs, to be very honest with you, does tend to throw a wrench in the plans. Maternity leaves, it's tough with a low number of specialists outside of St. John's who are providing some of this care. Things tend to have long wait lists, to be very honest with you. Okay. So now let's talk about our stream-based opportunities. So right now within Nunifam, in the first year of their family medicine 2-year block or 2-year residency training program, oh my goodness, what is the new RPC, Residency Program Committee, or Residency Training Program? They do 2 weeks of a geriatric consult service in St. John's. They also do 16 weeks of half days of long-term care per week, so a half day per week of long-term care consults and long-term care patient assessment. They also do 8 weeks of a half day per week of house calls or the home dementia program. And then obviously, they're getting a lot of this longitudinally through their family medicine rotations and their other rotations. So this is specifically in the first year, and except for the longitudinal experiences, the first 3 bullet points occur in St. John's during that part of the Nunifam program. The East Van program, again, in the first year, has 2 weeks of geriatric consult service, similarly the 16 weeks of half day of long-term care per week, and 8 weeks of half day of house calls or the home dementia program, half day per week. And then again, longitudinally through all of your other rotations. So very similar between Nunifam and East Van. In West Fam, it's a little bit flexible in terms of when somebody does their care of the elderly training. What it looks like if you have a 1-month block. So technically, all of the learners in the Western Zone are scheduled for block older adult care learning. They would do 2 weeks of outpatient geriatric outreach consult clinic, and that would be long-term care, home visits, personal care home, clinic-based consults, and also some longitudinal work with the home dementia program. 1 week at our restorative care unit, and then 1 week on the acute care of the elderly unit. And of course, as with all the programs, longitudinally through our other rotations. In CenFam, in second year, there's 2 weeks of the geriatric consult service with Dr. Noftel, and then longitudinally through the family medicine rotations. And of course, where it is just Dr. Noftel in the central region, in the central zone, it is obviously a challenge because right now she's off on maternity leave. So they do try to organize around that. When she is available, these are the opportunities that are available. And then NORFAM is longitudinally through family medicine blocks. They also try to organize for long-term care blocks with the preceptors to ensure that learners are getting long-term care dedicated experience longitudinally, but also from a continuing care perspective. There's also a new service where Dr. Kathleen O'Donnell flies to Goose Bay and offers consult-based travel clinics. And when she's there, the team in Goose Bay will pair learners with her for her clinics. So those are all of our stream-based opportunities. What I will say, and one of the things that was requested of me for this presentation, is almost a more detailed survey. Because as we know, depending on where you do your academic family medicine rotation, your experience can be really diverse in terms of how you're meeting these competencies in academic family medicine. In the future, I would love to survey each of the academic family medicine sites to see how people are organizing their older adult care or what opportunities exist in the academic family medicine sites. But unfortunately, outside of Corner Brook, it was a little bit too difficult to survey all of them in time for this presentation. So if that's something that's of interest to you, let me know. I'll see if I can get the information over the next little while. Should make a note to myself so I don't forget to bring that back up again at the end. So then that's our learners. That's our learners' experience as they go through their 2 years. Now, what I'd briefly like to talk on as faculty is what the comprehensive geriatric assessment is and what frailty is, so that your learners can benefit from your knowledge. Also, for you to understand that a lot of the comprehensive geriatric assessment, though it seems daunting because it's a massive, massive tool, is family medicine. A lot of care of the elderly is the stuff that we're doing on a day-to-day basis. The only difference really between my job now with care of the elderly and my job in my fee-for-service family medicine practice is I have so much more dedicated time to pull it all together into one single comprehensive plan with a comprehensive geriatric assessment. But in my fee-for-service family medicine life, I feel like my longitudinal relationship with my patients gives me the information to fill out this assessment in a way that I am not able to do in my single photo on the day that I see a patient to do the full comprehensive geriatric assessment at once. So we're going to briefly talk about the comprehensive geri assessment. But what I'd like for you to do is understand that this is not something that I would ever recommend anyone try to do in family medicine, because it takes me, 2 hours to really get all the information and assemble it all together and to do all the testing. But to maybe think about how in our family medicine lives, we do this longitudinally automatically, and how we can pull those bits and pieces together to help make decisions for patients when the time comes. So what is the CGA? The CGA is an evidence-based tool. It is a tool that, in theory, no matter where you go in the world, will collect the same information on a patient. Now, the forms itself will look different. We use a standardized form across Newfoundland and Labrador if you ever see our paper-based copy, but there are also copies on our EMR that have been made electronic, and in theory, as we move into a new health information system, it will be more standardized. But again, all collects the same information. What a CGA does is it allows for an understanding of the full patient picture. So their medical history, their psychosocial history, their functional status, and it allows us to really get a clear idea of all of those things and identify where patients have strengths and where they might have challenges in order for us to create a care plan. And so the CGA, in theory, can be completed by a single individual, and it often is in Newfoundland and Labrador because we don't have the multidisciplinary team that is doing this comprehensive geriatric assessment in other areas. But in an ideal world, it would be completed by a multidisciplinary team. And as I show you the components, you can understand why there are certain parts that would be very useful if you had a social worker, a physiotherapist, an occupational therapist, a pharmacist. So where do CGAs happen? In our province, community outreach clinics, the home dementia program does start with a comprehensive geriatric assessment of your patient. The community paramedicine program is a new program that is not launched province-wide yet, but exists in eastern and western zones. And it's a program that is paired with the, in part with geriatric program, but also has partnerships with palliative care, with the emergency department, and with the IV infusion program. And so they're doing mini comprehensive geriatric assessments on your patients that will be uploaded into EMRs as time goes on. In acute care, in areas where inpatient consults exist, comprehensive geriatric assessments are being done on a consult-based service or a consult-based basis. But in theory, as these ACE units open up and are fully staffed and are operational, any of your patients who end up in an ACE unit should get a comprehensive geriatric assessment. And the reason I put in where this is being completed is a lot of your patients may actually get a comprehensive geriatric assessment through some point of access to the medical field or to the healthcare system. The other one that I forgot to list here, in Eastern Zone, there are geri nurse practitioners in the emergency department who may be doing comprehensive geriatric assessments there as well. So if you find that your patient has entered the healthcare system through any of these points of access, you should have access to a comprehensive geriatric assessment on them, which would give you lots and lots of lovely information. I know in Western it's stored on Meditech under medical record forms. It is also available dictated for patients who are seen in the outpatient clinics through Health ENL. But do a little bit of digging to see where it's stored in your local region. So who needs a CGA? There isn't really a criteria for who should receive one, but in an ideal world, anyone over the age of 65 living with some degree of frailty, and we'll talk about that diagnosis of frailty in a bit, and who has one or more geriatric syndromes. These are our geriatric syndromes, and I'll leave them there for you to read. Susan's got a question there in the chat to see if anyone knows where these CGAs are housed in Eastern. I suspect one of the Care of the Elderly colleagues online might be able to give you that information. So these are our different geriatric syndromes. The challenge with saying that anyone 65 who's frail with a geriatric syndrome should get a CGA is that we just don't have the resources for that. Our wait list in Western for non-urgent consults is over a year. It's similar in Eastern. I presume it's close to that in Central. It would just be impossible for us to get a comprehensive geriatric assessment done on anyone who would benefit from one. But in theory, as we get more people who are identifying frailty and more people who are doing these assessments, I hope that every frail older adult gets one at some point in their life as an older adult. It's not something you repeat, you do it once and then it's done. So what does our CGA accomplish? It allows providers to understand a patient's frailty. Again, we'll get to that later. But it also captures information in a lovely document that facilitates creating a comprehensive care plan all in one place. But you can appreciate, as a family physician, it is very, very difficult to get all that information in one place when your time is 10, 5, 20 minutes with one patient. So this is the information we collect in a comprehensive geri assessment. And again, when I see this list, I think about how I have a lot of this information already as a family physician in my fee-for-service practice. So I know the story up until now. I have already gotten a list of their medications. Now, have I done a thorough medication review? Maybe not, but certainly, I have the ability to do it because I have that information. Social history, I often know well as a family physician. Geriatric syndromes, so mobility and continence and pain and elimination and intake, like nutrition. Often I have a concept of that as well. A functional review, so how well are they doing their instrumental and basic activities of daily living? Are the impairments in those things based on cognition or based on physical function? A cognitive review, so has their cognition changed and which cognitive domains are being impacted? A physical exam, and then some special testing depending on the patient. So with cognitive impairment, you might consider doing a cognitive test. I put the GDS, the Geriatric Depression Scale, in there as a lovely evidence-based tool for looking at depression in older adults, because SIGI CAPS is not validated in older adults. Falls risk assessment, which is part of the objectives that our residents need to know by the end of their 2 years. So there's lots of special testing that you can do, but I think as you guys are all aware, this is family medicine stuff. Like we can all do these types of special tests. There are some really nuanced specialized tests that I've seen in my care of the elderly practice, but the basics, the things that I need for the run-of-the-mill patients, the ones that don't have weird and wonderful problems wherein I'm phoning a friend anyway, those are all tests that I would do in my family medicine practice as well if I had the time. So what is our outcome? At the end of the comprehensive geriatric assessment, we identify frailty and we've made a comprehensive care plan. And the comprehensive care plan should be a plan that follows people through their life as we make sure that we're doing each of the items on the care plan and we're following up on them, and then maybe we modify the care plan a little bit, but it should be something that follows people into the future. And as I'm sure you're aware, that is definitely a challenge with our current information keeping systems, is how do we get that information from one point of access to another? So what are the challenges with the CGA itself? It's time consuming. It takes up to 2 hours to complete. As I mentioned earlier, a lack of resources. It's tough for one person to do these things. In a perfect world, you'd need allied health professionals with every family care team in every community, with every clinic. And then, of course, there's a lack of care of the elderly and geriatric internal medicine physicians and geriatric nurse practitioners who you can refer to, and they often have very long wait times. And of course, my last point of a challenge there is where are they stored? And as we're seeing in the chat, it is a bit tough to figure out where to find them if it's not all within one provincial health information system, which we're hoping to see soon. And then let's briefly chat about frailty. Frailty is, so some of this part of the presentation, I will give credit, is developed through the Family Practice Renewal Program Frailty Series. And so I don't take credit for this frailty portion of the presentation, but I will present it to you. So frailty is the concept that as we age, we're at an increased risk of bad things happening. People are frail when they have more issues compared to others the same age, and they can't recover from bumps in the road as easily as they might have when they were younger, or to an age-matched person who has less complexity. Frailty changes how the person experiences the illness, but also it should change how we deliver healthcare to a person. So the frailty score that we often use, which you'll see in a little bit, comes from Dr. Ken Rockwood. Dr. Rockwood is sort of the grandfather of geriatrics in Canada. He's a geriatrician who's prolific in research based out of Halifax and is still practicing. So a lot of the research you'll see has Dr. Rockwood's name attached to it. And so he is very, very interested in frailty, how we measure it, how we follow it. In one of his studies, and this was a study from quite a while ago, frailty compromises an individual's ability to either take or to do functional things, really. So how we take care of ourselves, how we interact with others, how we move about independently in the world. And the older someone is, the more likely they are to have medical health problems. And the more medical health issues that we have, the more likely you are to have functional impairment. And as you'll see, functional impairment corresponds with frailty. He designed a scale called the Clinical Frailty Scale, which was created to put all of the information about a person's health and function in one place and easily identify frailty in our patient population in a way that should be doable at every point of entrance into our healthcare system. So the Clinical Frailty Scale, Rockwood's Clinical Frailty Scale, which hopefully is going to be the one that you'll see most in your EMR, in the comprehensive GERI assessments that you see. And as we move forward, hopefully something that we're going to be measuring in family medicine, because we are the people who know it best. The Clinical Frailty Scale is a 9-point scale that summarizes frailty and fitness. It can be completed by any healthcare professional. It doesn't need to be a physician. It's a judgment-based tool, but it gives you some ways to interpret it. But the goal is not to assess the patient as they are today. If they came into hospital delirious, having had a UTI yesterday, I don't want to assess what they can do for themselves today. What I want to do is look back to 2 weeks ago to see what their baseline is. When we complete the Clinical Frailty Scale, the results should reflect what they were before their acute illness, as I mentioned. We need to understand their baseline to help inform what our goals are in terms of care. But it often requires collateral history, because lots of people, particularly if they're impaired from a cognitive perspective, they may not be able to give you accurate information about what they're capable of doing for themselves. When we talk about function, and this is what the Clinical Frailty Scale is based on, we're talking about BADLs or ADLs and IADLs. So in case you're not familiar with this nomenclature, Your BADLs are your basic things you need to do to survive in the world. So it's feeding yourself, toileting yourself, dressing yourself, hygiene and bathing, and then transferring yourself from one place to another. Your instrumental activities of daily living are the things that are more complex and are required for you to live independently. And so that's driving and medications and technology, or sorry, and transportation and cleaning your house and cooking your own food and shopping. I put technology at the bottom with a question mark because in theory, this is something that's emerging. I don't necessarily assess technology every single time with older adults, but if an older adult was capable of technology at baseline and then can now no longer use it, that does show an impairment of function. It's just that not all older adults in this generation right now are comfortable with technology. So we can't say necessarily that we would include it in every set of IADLs, but we have to also remember that it needs to be a change from baseline. One thing I see a lot is especially older men who maybe worked away and their wife was a stay-at-home mother as her work. They're often very well cushioned in their IADLs, meaning that the wife has always done all the shopping. She has always done all the food preparation. He sits down and she puts a tea in front of him. He's never been required to do any housekeeping. And so we wouldn't know if he's capable of doing it or not because he's never been expected to. And so we can't really comment on his function in that domain because it's not a change from baseline and we don't really know what he's functionally capable of. And the other side of that coin is for somebody who may have an intellectual disability, they may never have been capable of managing their own finances, but just because they're not capable of it now from a cognitive perspective doesn't mean that it's a change from their baseline. So that's really important for us to remember when we look at function. So here now, after all that preamble, here's the actual clinical frailty scale. So this is Rockwood's clinical frailty scale, and it's the newer version of it. You may actually see an older version of this scale, depending on where you look in terms of our records for comprehensive GRE assessments or within the EMR, they're very similar. What's lovely about this scale is even if you don't read the legible parts, if you look at the pictures, you can sometimes tell where a person is in terms of their frailty. So if they're robust and running marathons like a number one, low frailty, they're very fit. And I think I go through this a little bit more in depth. Let's go through one by one. Here we go. So level one, very fit. They're not impaired at all in their higher level or basic activities of daily living. They move around regularly. For example, they may be taking cholesterol medication, but they're running the 5K at the park run this Saturday. That's a very fit person. Level two, they may not be impaired in any of their function, and they still may move around readily, but they are probably not as high functioning as somebody who is very fit. So maybe they're exercising occasionally or seasonally, but they're not consistently active all year round. But again, they are still totally independent with their IADLs and their BADLs. Your level three, these are people who are managing well. They're not impaired in their function, but they're not regularly active either. And so there's an example there, taking a cholesterol medication, recently had an MI, has some chest discomfort with extreme exertion. So they're not usually super active. And then you get to number four. Number four is living with very mild frailty. Here, you're still not impaired in function. So all the way up to mild frailty, or very mild frailty, you don't have functional impairments, but you might feel slowed up or being tired or not having the same stamina that you had previously. So when you're looking at the pictograms on the side, you can see this is somebody who may need a little bit of help getting around potentially with an adaptive device, but we're still in that very mild frailty area. And then number five, we're looking at, instead of very mild frailty, mild frailty. And here we see some change in function. So between 5 and 7, the pictogram tells us some things, i.e. this person might need a little bit of assistance physically, they might need somebody with them physically, they may be dependent for mobility. But the other thing we have to look at in these frailty readings is what do they need help with? So in 5, they need help with their higher level activities of daily living, instrumental activities of daily living. So they might need help remembering to take their pills or remembering to pay bills. But it's really only those higher level things that they need help with. The really important thing to remember here is that it doesn't just need to be physical. So if somebody is not able to take their medications because they have really severe osteoarthritis in their hands and they can't open bottles and they can't push the pack out of a blister pack and adaptive equipment hasn't helped, they're equally as frail as somebody who can't remember to take their pills from a cognitive perspective. And that's predictive. So somebody who has a clinical frailty score of 5 has a certain predictive indicator for morbidity and mortality, and it's equivalent no matter why you're a 5. So if you're a 5 from physical reasons, you're equally at risk as a 5 from cognitive reasons. And then when we get to 6, which is moderate frailty, they need help with everything outside the house. So, your lawn and your snow clearing, but they often need help with a higher level BADL as well. So they might need some cueing with dressing, or they might need some physical help with bathing. By the time we get to 7, which is severe frailty, you're looking at somebody who's completely dependent for personal care. Really, the difference between 5, 6, and 7 is their function. And that's why we really do need to understand IADLs and BADLs for our patients in community. And then 8 and 9. 8 is very severe frailty. Often this is somebody who a small bump in the road might be enough to end their life. So somebody who's severely frail may get a UTI, and that could be the thing that pushes them over the edge into not being able to recover from that. And of course, terminally ill is anyone who is end of life with a life expectancy less than 6 months. So the question is, why is it so important for us to identify frailty? As family physicians, why is it so important for us to teach our residents how to identify frailty? It's because how we treat the patient changes depending on where they fall in terms of their frailty. So think about the fact that, your 30-year-old patient is the green line. So they're very independent with their function. They get a minor hiccup like a UTI, and they might not feel well for a couple of days, but they bounce back and they get back to exactly the same level of function. As function decreases, so as we get down towards this red line, at baseline, this patient is independent. So they might be a clinical frailty score of 4, but they get the same bump in the road, the same urinary tract infection. It brings them lower. It makes them functionally dependent. Now they need assistance with their IADLs and BADLs. So the drop in function is much larger, and it takes much longer to get back up to a new plateau. And the new plateau in function is lower than where they were before the urinary tract infection. And again, this is looking at somebody who is independent at baseline. So you can imagine how low that drops for somebody who has functional dependency. So it's really important for us to identify frailty so that we can predict disease course, that we can prevent these bumps in the road that can cause functional dependence and deterioration in mobility and independence. So how can we use I think I'll get to it in this slide. How do we use the CGA as family physicians, and how do we use frailty as family physicians, and then how do we use it in training our learners? So as you probably recognized, the comprehensive GRE assessment can provide tools and can provide a photograph in time of a patient, but how we interact with our patients as family physicians who have longitudinal relationships is very similar in terms of the information that we collect and the plans that we make. What I find important about the comprehensive geriatric assessment in terms of teaching it to learners is the tools. So there are specific tools available, like how we set up our medication review and our problem list, like the tools that we use to assess mobility, to assess cognition, to assess mood. The tools themselves are very useful to take from the comprehensive geriatric assessment and bring with people into whatever their future career might be. The other thing that's really important is understanding the importance of knowing your patient as a whole. So it's not a system-based approach, it is a person-based approach. And also that our job is often more quality of life rather than quantity of life as patients become more frail. Frailty in and of itself is, number one, I think it's just important for us to really understand how frail our population is, and we're not measuring that yet. So if we can find ways to measure frailty, we can really look at prevalence of frailty and what that means to our healthcare system and what it could mean to our healthcare system as people become more frail over time, so that we can actually plan from a health resource perspective, but also plan to create older adult friendly healthcare systems and communities that can support people as they age into frailty. Another reason I find it very important to understand frailty and to specifically identify and chart frailty is because as people become more frail, our approach to them changes. Advanced frailty might mean that we no longer have somebody on preventative healthcare measures. They might not need, a statin anymore. As people's frailty progresses, their A1C goals, as per the Canadian Diabetic Guidelines, actually increase. So if somebody's been diagnosed with diabetes or is severely frail, either of those, their A1C goal is less than 8.5. And so that's very different from our current practice guidelines in diabetes. So it is really important for us to identify frailty because it might impact how we treat the patient in front of us and the different interventions that we might take on and obviously that we teach. And also because as we figure out frailty, and as you've seen through this presentation, creating frailty pathways, both for our patients. So once we identify frailty, say we say this patient has a frailty score of 7, that means that we should do a medication review, refer them potentially to medication therapeutic services if they have over a certain number of medications. Potentially they might, once they become functionally dependent, that might be a clue for us to refer to community services. So I think that there's potential to create robust frailty pathways within our province. I think we're very much a Goldilocks of not too big, not too small. And then the other side of that is frailty pathways for our documentation. Wouldn't it be lovely if we could actually transition this information from point to point once we've created these comprehensive plans, or even once we started the pathway for somebody in terms of their frailty, which would be something that I see really happening within family medicine. And so that brings me to the end. So I'm going to stop sharing my screen and see if anyone has any questions for me. I appreciate you sticking with me. I know this is a bit of a different talk, and I am open to suggestions in terms of other information you'd like for me to gather for you.
Thanks, Amy. I'll leave it open there. There was some discussion about where things were housed in Eastern in the chat that you mentioned that you saw. Anybody have any comments?
Thanks, Laurie.
I think it's really, gosh, it's good to go back to basics to, kind of look at this information again, certainly with the lens of the learner, as well as for what we do clinically. So I think that's excellent. Thank you for presenting it that way. Also, just as a little aside, some of us knew or know Dr. Rockwood because he was a MUN grad, and certainly have followed his journey over the years as a geriatrician. So certainly he's done a lot of research, as you said, and a lot of writing about the elderly. Any other comments?
If anyone's typing in, let me say, even if you're teaching or working in an area that doesn't have a dedicated care of the elderly or internal medicine service, one of the things that we will be launching as of June 2nd will be a provincial geriatric call service, which means that if you want advice, if you want to run something by someone for any of the geriatric syndromes, whether that be BPSD and dementia or somebody who's failed a bisphosphonate or falls, that's what we're there for. So there will be a provincial call service that you can reach through your switchboard as of June 2nd. And don't feel at loose ends when you have a patient who you've referred, knowing that there's a huge wait list. We're also available via e-consult, but also, I think most of us would be very happy to hear from you by text or email or call if you wanted to chat about anything.
Excellent, thank you. And again, this is something we see every day, our learners see every day, right across the spectrum, as you said at the beginning, in multiple rotations. And so would be nice to have something that so that there's some continuity. I think Susan Avery has a question. Can you remind me at what entry points a patient would likely have a GCA completed?
Sure. So it depends on what region you're in. Let me just start with acute care and I'll clarify as I go. So if a patient presents to the emergency department in St. John's, the St. John's emergency departments have or will have in the near future geriatric nurse practitioners. And so it's possible, depending on screening for your patient, that they may get a comprehensive geriatric assessment in the emergency department if they're quite complex. And again, those who are in the Eastern Zone can correct me if I'm missing anything on this. They may get a comprehensive geriatric assessment. It may be arranged for outpatient follow-up. That's one point where somebody may receive a comprehensive geri assessment, but that is only available, to the best of my knowledge, in St. John's right now. On acute care, once the patient's admitted, in St. John's and Corner Brook, patients may get a comprehensive geriatric assessment if they are consulted to care of the elderly geriatric service for a Jerry syndrome or advice in hospital. So it's possible your patient may get a comprehensive Jerry assessment in acute care, either in St. John's or Corner Brook. As in St. John's specifically, once restorative care opens, if your patient goes to restorative care, every patient going to restorative care in St. John's will have a comprehensive geriatric assessment. At least I understand that's the plan. So you know if your patient went to restorative care, they will have a comprehensive geriatric assessment in St. John's. That's not necessarily true for the West Coast. In the community, if they've been referred to and seen by geriatric services in any of our in any of our 5 zones, they will get a comprehensive geriatric assessment on their first or second visit. So it may be split into 2 depending on where it's being done. But if they've been seen by geriatrics, what they do in those first 1 to 2 assessments is called the comprehensive geri assessment. And then the other places they might get it is the home dementia program in Western, Central, or Eastern, or the community paramedicine program for the most part in Western, but also potentially in Eastern.
Excellent, thank you. So we'll make sure we send the link or the information in case any other faculty want to review this presentation, because it's very comprehensive and certainly a lot there that people are learning about. There's a comment there from Jennifer. Typically all of the GCAs that are done in geriatric medicine outpatient clinics have notes dictated. These are asked to be copied to the family doctor if there's one involved. And I've received many. I'm sure most of us have, and find them very, very helpful. Okay, well, if there's no further questions or comments, I'd like to thank Amy very much for coming and doing this presentation for us this afternoon. Like I said, I think we're all taking away something maybe for ourselves as well as for our learners. So thanks so much. Take care, everybody. Have a good rest of your day.
Thank you. Thank you.
Thanks, Amy.